I am going to discuss about arch anomalies. This would be obviously beyond the right-sided aortic arch in the fetus. I'll be discussing fetal arch abnormalities. Many of us do still believe that arch abnormality diagnosis and the management is little difficult, but I try to demystify the complex things. At the same point, I would share with you the rarest possible arch abnormalities, whether I have seen those patients or I haven't seen them, and few of them I picked up from literature, so that I kind of compile everything together in this one single talk. I would keep on delivering more and more information to you guys, and it's a good idea to subscribe the channel. That indirectly encourages us to perform little better, put more videos, so that we know that people are liking it, and we are giving you something which is useful to you in your day-to-day clinical practice. So do subscribe right away. I don't like cardiac embryology, but once you are talking about the arch abnormality, we understand that understanding of embryology is very useful in this area. Now we know that it develops, the cardiovascular system or the arches develop from ventral and dorsal aorta. There are two, they are in pairs. So two dorsal aorta and two ventral aorta, and they connect with these branches, and these are called 1, 2, 3, 4, 5, 6 arches, which would resolve of its own to form a final structure what we see. Okay, so based on that, we have a hypothetical model of I would go a little slow here, because understanding this would be very, very important to you in understanding my lecture in subsequent slides. So I would go slow. In case you already know about it, you have an option on a YouTube to increase the speed to 1.5 or double the speed in the settings. So now this is the arch what we have, hypothetical double aortic arch, and if this portion disappears, this forms as one type of an arch, and this is the normal left-sided arch. And if the absorption happens here, and this is the segments which get absorbed, and then you can get the rest of things manifesting as, let's say it's an URSA, then from the embryology you can actually make an assessment of various branches of the arch. So the embryology understanding is very important. I'm going to spend 5-10 slides next to explain you that, and that is what is the trachea esophagus in the middle, and then the hypothetical double aortic arch is around, and that's the right coronary artery, common carotid, right subclavian, left common carotid, left subclavian, the right ductus arteriosus, the left ductus arteriosus, and the pulmonary artery branches. So you have two arches going like this hypothetically, right? So if you've understood this, I'm going to move a still ahead. Now this is hypothetical double arch, based on which we can actually make out all possible combinations, even rare, of arch abnormalities and the branching pattern based on that. Now if we have these two portions which resorb, the branches are absorbed, and then this is our normal left-sided aortic arch with left ductus, and that is what is normal. Here, by absorption of this, you see this is the ascending aorta, and this portion becomes brachiocephalic, the common trunk from which right common carotid, right subclavian would emerge. Is that normal? That's what you see? Exactly. This is exactly what you see, the brachiocephalic, and as the arch goes along the left side, you see the left common carotid and the left subclavian arteries. So there are actually 1, 2, and 3 branches come out of the arch of aorta, and then this is a descending aorta which is singular, which goes to the left side behind the esophagus and trachea, and normally you have a left ductus arteriosus which is patent during the fetal life. Let us come to another scenario. Let us see, in case the right ductus disappears or is absorbed and this portion of the arch is absorbed. Now what is the situation here? Now situation is that you have an aorta, ascending aorta. Instead of brachiocephalic, you get only right common carotid arising from the aorta. The next branch is left common carotid. The third branch is left subclavian, and as this portion has not been dissolved or absorbed, then this forms a retroesophageal course to give origin to anomalous right subclavian artery. Right, so this makes sense, absorption of this, and this is a patient or a the fetus with URSA or anomalous right subclavian artery arising as a fourth branch from the aorta. So again telling you that this was supposed to be a common trunk for right common carotid and right subclavian artery if this portion had not been reabsorbed, but in this situation they are separated out, and now this route is taken by a retroesophageal course to give, so this portion of the arch is maintained. So that is URSA with everything else being normal. Let's take another example. So rather than this side, if this side as a mirror image is absorbed and it disappears, and the right ductus arteriosus which commonly disappears, instead of this place, if this is the portion which disappears, this becomes watch. Now this left side of the arch stops here, and left side of the arch now becomes what? Common trunk, that is innominate artery, giving rise to the left common carotid and left subclavian artery, while this portion, the right sided aortic arch which goes on the right of the aorta and esophagus, gives rise to right common carotid and right subclavian. This is typically called right sided aortic arch with left ductus arteriosus. The ductus arteriosus is on the left side, and this is a mirror image branching. What do I mean by mirror image branching? In the pediatric cardiology on a neonate, this is how the right sided arch is identified. Now the first branch, which normal arch would have been this, but in this the first branch coming from the ascending aorta becomes this. Agreed? Because this is exactly the mirror image, and the first branch becomes innominate artery. This becomes innominate artery, left common carotid, left subclavian artery. The first branch from the aorta, rather than going to the right, goes to the left and bifurcates into two, and the right sided aortic arch continues further and gives rise to only these two branches. So this is a mirror image branching, or a common what we see as a right sided aortic arch with left ductus. Now the next example, let us say the absorption happens not here. Likewise, once we had an absorption happening here, you had an URSA. Now if the absorption happens here and it does not happen at this place, this is the right aortic arch with the first branch being left common carotid, second branch being the right common carotid, the third one being right subclavian, and the left subclavian comes retroesophageal and goes to the left side. This is the right sided aortic arch with left sided ductus and ULSA. Alright, so next give you another example. Now this is an example which is a very uncommon, that you have next this thing which is not as common as the left-sided ductus, you have a right-sided aortic arch. Agreed? So rather than left ductus remaining and right absorbing, it is the right ductus which stays. Otherwise, this is exactly the same as that the right-sided aortic arch with left ductus. Right-sided aortic arch absorption of this portion is common, but the difference between the right and left ductus is that which ductus disappears. In case left ductus disappears, it's the right ductus. The aortic arch and the ductus are on the right side. You can come back to these again once you've seen the examples in the fetal echo and to revise that how these things are happening. Now this is a patient with right left-sided aortic arch, that is normal, and the right-sided ductus. This is extremely rare example. I am showing you here because I am going to show one case which I seen with the left-sided aortic arch and the right-sided ductus. Aortic arch is normal, it is the ductus which is abnormal. So what is the importance of the arch abnormalities? If you miss, let us say, a right-sided aortic arch, which can be easily missed, but then you miss these clues also, because right-sided aortic arch is generally associated with genetic malformations, most common being micro deletions, and apart from that, the aortic arch, in case it forms a vascular ring, can lead to tracheal and esophageal compression, which I am going to share in the last few slides of my talk. So stay till the end, because I am going to share the clinical relevance and importance at the end of my talk. Now, assessment of arch abnormalities, let us know the normal. So now I am going to fetal echo scanning, and how do you see those the cartoonistic arches which I showed you in the real life in the fetal heart scanning. Now here you have the thymus, right? This is the 3-vessel trachea view. In the 3-vessel trachea view, where do you get a 3-vessel trachea view? Is that when you go cranially from the RVOT view with a little angulation, you would get these 3 vessels. One is pulmonary artery, aorta, and SVC. The size is again in descending aorta, PA being the largest, aorta smaller, and smallest being the superior vena cava or a right-sided superior vena cava, and trachea comes here. Now both this aorta and pulmonary artery are faithful to each other. They go along with each other, and this is the ductus and this is the aorta, that is isthmus, and the V is formed on the left side. So this is the left side, and both arteries go to the left side to form the V. So now I am going to tell you very important aspect, that once you are trying to assess the arch abnormalities, you look for 3 things. What are those 3 things? Number 1, which side is the aortic arch? And how do you decide that which side is the aortic arch? The trachea decides it. Which side of the trachea the aortic arch is going tells you whether it is going on the left side of the trachea, or is it going on the right side of the trachea, or it is a double aortic arch. It's going on both sides of trachea. Agreed? So that is number 1. Now the question which you are going to ask, number 2, is where is the ductus? This is the ductus. In this normal fetus, aorta lies on the left side, aortic arch lies on the left side, the ductus lies on the left side. Left-sided aorta, left-sided ductus is normal. So that is ductus. Pulmonary artery connecting with the isthmus is ductus. So now the side of ductus. Is it the left-sided ductus? Is it the right-sided ductus? Or occasionally or very, very rarely you can have a double ductus. I haven't seen any patient yet. The third most important thing is to know the branching pattern. Okay, is it the mirror image branching, the normal branching, or anomalous origin of coronary artery, the subclavian arteries or carotid arteries, the arch arteries, if they are originating abnormally either from different part of the aorta or from the pulmonary artery. So three things important are side of the arch, side of the ductus, and the branching pattern of the arch arteries. So again, giving you an example that if we have, this is the normal left-sided aorta. So I would now first I am going to discuss the common things. The common garden variety of arch abnormality, which you all would have seen once in a while. Once I finish this common abnormality, I would here tell you few tricks and tips that how not to miss certain important vascular rings which have an important bearing on the neonate and the surgery requirement in the future. So stay till end because I am going to share that important prognosticator factor when you are assessing the arch abnormality. The commonest arch abnormality which you all guys see, which is one of the markers of aneuploidy, soft markers, and then I think these are my old kind of pics, and you know the left subclavian artery, the right subclavian artery arises from the aorta rather from the brachiocephalic and goes behind the trachea. So this is behind the trachea, this is the trachea, and it goes behind the trachea. This is the right subclavian artery. We call it anomalous origin of the right subclavian artery, which is URSA, going behind this, and that is the axillary artery, and that's the vertebral artery. It divides into two. But these are not the great picture. You guys must have taken wonderful pics of URSA. But URSA, apart from having an association or a mild association with aneuploidy, is otherwise benign. Occasionally, URSA can produce some degree of esophageal compression as the child grows and can produce mild dysphagia called dysphagia lusoria. So then you must be cautioned that this looks like this is the trachea and this is the red flow. This looks like an URSA, but URSA should have gone this side toward the arm. This vessel is having a continuous flow. What do we mean by continuous flow? You see a pulsatile flow in the aorta and pulmonary artery, right? It is blooming and going away, blooming and going away, but this is continuous, and this is entering into the right superior vena cava. So what does enter into right superior vena cava? Exactly, that is an azygos vein. So don't mistake azygos vein. That is URSA down here. This is the pulmonary artery, the aorta, the trachea. Now you see the URSA, but also the left superior vena cava and azygos vein entering into superior vena cava. So that was an example, again a pathological stuff which I am showing you from the hypothetical model, that if the absorption rather than happening here, which would have created a normal left-sided aortic arch, this absorption happens at this place in between the right subclavian and this, and aorta, there is one vessel coming out of this in the right common carotid, left and left subclavian, and then the right subclavian goes behind the esophagus and trachea to go to the right side. So this is what is URSA, which is pretty common. You see it and every now and then. Next, I am going to discuss about the right-sided aortic arch with the left ductus. So I told you there are three things which you look for. One is you look for which side is the aortic arch. So it is aortic arch has gone to the right of the aorta, correct? And look for next thing is look for the ductus. Ductus is not on the right side. Ductus is on the left of the trachea. And how do you know that? Because the ductus connects with the right aorta and forms the U like this, because it has to connect, ductus had to connect with the aorta. So trachea comes in between, this forms a U, rather than if this had been on this side, that would have been a V sign. So this is right sided aortic arch with left ductus. What is the next thing to look for? Yes, the branching pattern of the arch arteries. Now I'm going to show you a couple of examples of a right sided aortic arch. You see this is the right aorta, this is the trachea here. You see this is the pulmonary artery, that is the superior vena cava, and this is the aorta. Rather than aorta going on this side, has gone across the trachea, not faithful to the pulmonary artery. Trachea comes in between, and this is how it looks like on a 3D. Let's say this is the trachea, and you see the pulmonary artery going towards the left side, but aorta, rather than turning to the left, goes on the right side across the trachea, and this does not form a vascular ring. This is open anteriorly, right? So this does not form a vascular ring and does not cause any compression. Vascular ring if it is enclosed from all sides the trachea. I would show you vascular rings very shortly. Now this is again the same aorta and pulmonary artery forming a U, and that is in the middle. You have a trachea, you have one branch of pulmonary artery going that side, this is the trachea, and that is the ductus here, pulmonary artery, and that's an aorta going around the trachea. Okay, now again you see this is the SVC. You see this is the aorta, which should have gone on this side, has gone on the right side, and you can recognize pulmonary artery by its branching. Not only that, if you can see little carefully, I am going to show you, this is the subclavian artery, and you have what? This is the persistent left superior vena cava. Correct? This is persistent left superior vena cava. That's the right superior vena cava. And in about 30 to 40% patients, the left superior vena cava and the right superior vena cava are communicating with brachiocephalic, but commonly the brachiocephalic is absent. You have a left superior vena cava, you have a right superior vena cava, left draining into coronary sinus, right again going into the right atrium, finally both going into the right atrium anyway. And if this brachiocephalic presence does not rule out the the persistent left subclavian vein, SVC. So, right-sided aortic arch with the left ductus, this is the classification. Right-sided aortic arch, this is how it looks. So, as I told you, once you've decided the aortic arch is on which side and which side is the ductus, the next step is what? Branch arteries. Exactly. So the common thing is right sided aortic arch and with left ductus and ulsa. Okay, right sided aortic arch with mirror image branching and right sided aortic arch with isolated left subclavian. Very, very rare, but I would tell you this as an example at the end of my presentation. So now we know the incidence of right-sided aortic arch with left ductus. It's not very rare. It's 1 in 1,000. It is a very normal and a very good outcome, except for in minority it would produce some kind of swallowing difficulty, but very, very rarely it can form a ring by atretic double aortic arch. I'm not going to discuss that. Now this is what is a right-sided aortic arch with a left ductus. Okay, and mirror image branching. What is the mirror image branching? The examples which I showed you is that the right things coming from this side, and the very first branch which I told you from ascending aorta goes to the left side. This is left innominate way artery branching into two. That is the first branch, which is paradox to a normal, this being on the right side. So this is mirror image. Occasionally the mirror image may not be there. You can have an ulcer, the left subclavian arising from the descending aorta. So I'm going to show you the example. That is, you have this is a superior vena cava, that is the brachiocephalic vein, this is the trachea, on the right side this is the aorta, and this is on the left of the trachea is pulmonary artery, and that is the ductus which is on the left side. Now next step is, once you see this, you see this artery which is going on the right side is ulcer or anomalous origin of the, okay, so this is ulcer, not ursa, sorry for misspell. So again, this is the patient with the right sided aortic arch. This is SVC, aorta on the right side, and on the left side you see the subclavian artery going behind the trachea called ulcer. Another example of a right sided aortic arch, SVC, aorta, trachea, pulmonary artery, the ductus on the left side, and on the left side you see this artery going behind the trachea called ulcer or anomalous origin of left subclavian artery. Right, so this is how embryologically it looks like. Instead of the resorption here, the resorption happens at this place. You have right sided aortic arch with the subclavian artery coming from behind the esophagus and going to the left side. Now I'm going to show you an example of a right sided aortic arch with the right ductus. Here pulmonary artery also decides to go with aorta on the right side. So this is how it looks like when you are scanning right sided aortic arch with the left sided ductus and right sided aortic arch with right sided ductus. Trachea, the ductus also is on the right side. It forms a V on the right side rather than on the left side. I would show you examples here. So that is the right ventricle, left ventricle. You have a pulmonary artery. Aorta arises from here, goes behind and goes to the right side. That's the right side. This is the SVC. The aorta goes to the left side. There is a trachea here. I'll show you the next clip, and both pulmonary artery and look at this. This is the trachea. Both pulmonary artery and the aorta are on the right side. Okay, so right side of the trachea. So that means the aortic arch is on the right side. The ductus is on the right side. Right. So this is a right sided aortic arch with the right ductus. Another example of a right-sided aortic arch with the right ductus, and that is the right ventricle, the pulmonary artery, the aorta, and that is the trachea. It's on the right side, and that's how it is. Now this was the example. Now I'm going to discuss with little more unsafe situation, that is the double-sided aortic arch. This is infrequent, not rare, but you see one or two patients in some time. You also must have seen a few. And what happens, both arches remain intact, and now you see it forms a full circle around the trachea, and this is what is called a vascular ring. Now as the child is born, the flow in the aorta increases. Now when the increase in flow, the aorta actually both sides they become larger in size, they compress both trachea and esophagus. Tracheal compression is more important. It produces respiratory disturbances, stridor in the patients of double aortic arch. Initially, if you don't see the aortic, the ductus connecting each other, you can see this like a mu sign. Okay, this is the pulmonary artery. The aorta proximal to the trachea divides into two. SVC, aorta and pulmonary, the aorta divides into two here, right? Aorta branches into two. This is the right arch, this is the left arch, right? So this is double aortic arch, and that's what the difference between a U forming like this, where the arteries are joining at behind the trachea, but if it bifurcates in front of trachea, this is a double aortic arch. Showing you an example of a double aortic arch. Remember, which I am going to tell you next slides, is that right-sided aortic arch, many a times the right arm or right arch is dominant and the left one is smaller. Okay, this is a very important aspect of a double aortic arch, which I am going to tell you in next couple of slides, and you can miss double aortic arch, and which would be dangerous, because child can have problem early in infancy or even as a neonate of respiratory problems. And now you see the aorta dividing into two and forming a full circle around the trachea, which is what we call as a vascular ring. Now, as I shown you, both the arches usually may not be of the same caliber. Many a time the right one is bigger and the left one is hypoplastic or small. Let us say the left one is very small, or actually is become atretic, would leave a band here, right? This is one band here. Here would be trachea. This is the left, the right-sided arch, and this is still, even if you cannot see any flow, this atretic strand can produce a vascular ring across the trachea and can compress the trachea. There is a classification of a double aortic arch depending upon which side of the arch is dominant. Balanced type, where we have a right arch which is dominant, left is thinner. Then there is a left dominance, the left arch is dominant and the right one is thinner. What is the percentage? Yes, balanced ones are only 17%, majority being a right dominant and again small number of left. So in case you have a right dominance and you don't see this branch on this side, you are going to miss double aortic arch. You would say this is one pulmonary artery, this is the aorta, and you are going to make it as a right-sided aortic arch if you miss this branch, which may be smaller, of the right double aortic arch. I would show you examples here. Now this clearly shows a right one is dominant, it's double the size of the left. Agreed, going across the trachea. Okay, so this is double aortic arch forming a mu sign. Now this looks like a right-sided aortic arch. Would you agree with that? I would enumerate the structures here. This is a superior vena cava. This is the right-sided aorta, which is gone to the right of trachea in the middle. And this is the ductus, which remained on the left side. So this is right-sided aortic arch with left ductus, the U sign. So you were happy till here, but you saw a small branch, from the aorta going like this, encircling the trachea. So see, we would have missed this in case we did not focus and attention of a bifurcation. So whenever you see a right-sided aortic arch, Please search carefully once, twice, thrice in various orthogonal views to rule out double aortic arch. So all right aortic arch can be, a good number in those right, so-called right sided aortic arch could be double aortic arch. So don't miss that. So show you an example. This trachea, this is a right-sided aortic arch, this is an esophagus, this is the SVC, trachea, pulmonary artery, and this is the aorta going on the right side, and this is trachea. I would have made the diagnosis of right-sided aortic arch till I saw this branch. Okay, I go little cranial, I see this branch. So the right sided aortic arch becomes a double aortic arch. I am giving patient a normal and good, happy outcome with the right sided aortic arch. But with the double aortic arch, there is a caution. I tell that patient would have to visit a neonatal unit immediately after birth. So there are articles being published, and we now recognize about 30% patients where we make the diagnosis of right-sided aortic arch, 30%, they turn out to be a double aortic arch, right? So be very cautious, careful, not missing double aortic arch and making it right-sided aortic arch. Why? Repeating again, the left arch may not be dominant, may be smaller, the right arch may be bigger, so the left arch may be missed. So if we miss that, the right-sided aortic arch, and we say that this is a kind of a double aortic arch. What does happen in double aortic arch? Why the prognosis, the outcome is different, and we need to counsel the parents accordingly. Reason, if there is a double-sided aortic arch, it is the definite sign that it would compress the trachea as the child is born. Not only that, it would produce, even in the fetal stage, people have documented compression of the trachea, and it produces tracheomalacia. Few rings, cartilaginous rings, do not develop well in that area, and subsequently the trachea also might need some therapy or surgery. So tracheal compression can happen in the fetus, it happens in the neonate, or even later. The predominant factor which we people have noticed is that if you have both sides being vascular, one atretic and one vascular, probably chances of compression is less, and in the sized arches, that is none is dominant, the chances of compression of the trachea is higher than in the groups where we have a left with aortic arch which is not. So inequality makes it little safer for the neonate. People have tried to document the tracheal compression very recently. This is a paper from China last year published, and trying to show the trachea in a sagittal view branching into two and showing the distal portion of trachea being narrowed by in between the right and left aortic arches, and they were able to make that this difference is statistically significant between the normal feti at that age, and people have tried to make in an inversion mode, trying to show tracheal compression, which is quite clearly seen in the neonatal period. So this is the double aortic arch and causing a compression in the neonatal period, which now we can pick up in the fetal stage also. So these are various vascular rings which I have discussed. Left double aortic arch is the commonest way vascular ring. I am going to show you two more vascular rings. Other vascular rings are pretty uncommon and rare. You may not see a patient in your lifetime. Let me tell you about few cases which I have done in last about a decade of uncommon arch abnormalities and rare arch abnormalities. So this is the things which I have not seen as yet or not focused is branching abnormality, the Bowman type, These have no practical significance in real life, because branching does not really make a great difference except for the subclavian artery, which is aberrant. Bilateral ductus arteriosus, I haven't seen it before, but this is I picked up from one of the journals published. Both sides there is a ductus arteriosus, and if the ductus arteriosus stays patent, can produce a vascular ring. I am going to show you an interesting case of a vascular ring. Interestingly, you notice this is the spine, this is the left ventricle, this is the left side, and that's the right side. Left atrium, fossa valis, the pulmonary veins. But you notice aorta is slightly to the right of the midline. Agreed? So this tells me that the descending aorta is on the right side. So right descending aorta, and again in the abdominal view you see the aorta still continues to be slightly on the right side of the spine. Now next view is that you see the pulmonary artery, you see the branching of the pulmonary artery. Very rarely, in fact, you would see the pulmonary artery trifurcating, because you don't see it because the ductus arteriosus is at a different plane. Normally what you get is the right pulmonary artery, the left pulmonary artery, and a ductus arteriosus. Here the ductus arteriosus, because it's moving to the right side, has come to the right of the trachea. Notice this, it has come to the right of the trachea. This is the ductus, this is the trachea. Now the ductus is on the right side. The step 1 in arch abnormality, remember, was what? Which side is the aorta? Correct? So let us see. Ductus is on the right side, we know that. Now, which side is the aorta? Now, that is an aorta. You would see it shortly. Yes. Aorta is going normally to the left side. Okay, that is the aorta which is going on the left of the trachea, and that is superior vena cava, and the pulmonary artery is going where? Pulmonary going artery and ductus are going to the right. So this is the trachea, right sided ductus, but left sided aortic arch. Extremely rare. About 10 odd cases have been reported in the literature. The very interesting phenomena what happens is there is a double crossover. The aorta and pulmonary artery cross at the LVOT and RVOT level, their outflow levels. Then they cross again. Now the aorta goes to the left side and the pulmonary artery and a ductus goes on the right side. So they cross double. Okay, one cross here and this is the second cross here. So this forms a kind of a figure of 8 on a three-dimensional this thing. You see this is one crossing here, the pulmonary artery, the aorta crossing from here, and then they are crossing again on each other, right? Okay, so this was given a cross ribbon sign. The very first publication was a cross ribbon sign was by Dr. Bhupati from India, and he given this name to this as a cross ribbon sign in the fetus. Other rare abnormalities which I haven't seen as yet is cervical aortic arch. Instead of number 3 being the forming the aortic arch, this number 4 arch is absorbed and the arch 3 is taken. So the aortic arch here goes higher, right, and comes back. This is how the aortic arch goes. And when we say clavicle, if the aortic arch crosses the clavicle up, clavicle and the aortic arch goes right, this is called a cervical. There are A, B, C, D, E classification. It itself is so rare. So once you see the cervical aortic arch, we can always look up the classification later. So there's no point remembering the classification now. Another very rare abnormality is when you have, this is the normal and the right sided aortic arch, and then there is a disappearance of this, and the left ductus is here, and the subclavian artery, you have a right ductus also which remain. The left ductus, the subclavian artery arises from the left ductus. Okay, so the area here also, let's say what happens in the subclavian artery, the left subclavian artery, in ulsa, this would disappear, right? And this would be intact. The left subclavian artery would come retroesophageal to go to the left side. Agreed? But in here, this connection also dissolves, this connection also, and the left ductus gives origin to the subclavian artery. So, subclavian artery arises from the left pulmonary artery through ductus and subclavian. That is how what it happens. I hope I was able to give you a simplified versions of a complex issues of an aortic arch. I have skipped just one or two very rare abnormalities of aortic arch, but try to cover almost all. The reason being, if you see a pattern, you know that these things exist, and by a chance, if you hit into such a thing, you don't miss it, you'll be able to make a diagnosis. If you really like the presentation, I think the one best thing you can do is to subscribe and like the channel, put some comments there. That interestingly is a good motivation for me and anybody else who is delivering a talk to go continuously further and make more and more educative videos and information. Thanks for watching, and I insist, please subscribe.